I'm going to make this brief so we can have some time for questions at the end. But I'm just going to talk a little bit about how we can start thinking about using comparative effectiveness research in some of our NF studies. All right, so as Pam described, comparative effectiveness research is when we're comparing two or more different treatments that are currently already in use to see which is more effective. And it really has been very rarely used in NF research so far. Most of what we've been doing has been looking at one particular treatment, comparing it to a placebo or control group and seeing whether that's helpful or not. I've already talked to you about our study using bone morphogenetic proteins. And the gold standard, as we discussed, is where you have a randomized controlled trial. So you have a group that is given no choice in which treatment their child is going to get. They're either going to be assigned to the experimental treatment or they're going to be assigned to the standard treatment. And generally that type of study is required to get FDA approval for a drug or a product. But the disadvantages of these kind of trials is that they're very strict enrollment criteria. Many patients are not eligible, and many patients have no say in which treatment they're going to receive. So getting the numbers of needed patients to determine the best treatment is still very difficult for rare conditions. And so that's why we made the change in our BMP trial to become what's called a participant choice trial. So with participant choice trials, the patient or the parent gets to choose which arm of the study they prefer, if they want the new treatment, if they want the standard treatment. It requires some changes to the statistical analysis of a study. Can greatly improve our recruitment to some trials, but it can be harder to get funding from different organizations for this type of research because they're often used to having the standard randomized controlled trials. There was a large bracing study that was recently done for adolescent scoliosis that used this patient preference technique to enroll patients because they were having a lot of difficulty enrolling patients. Many of them had a strong preference whether their child receive a brace or not. And so when they had that difficulty with recruitment, they ended up changing the trial and had a preferential choice arm of the study as well as a randomized study. And when they looked at the results from both of those types of studies, they had similar results. All of the results showed that bracing was most efficacious. So that did prove in that situation that a parental preference trial can still give you legitimate scientific data. So I already mentioned the modifications that we're making in our trial with the parental preference being allowed. Those who don't have a preference when they come into the trial can be still randomly assigned, and so we can still look at some patients that have been randomized in this study. You have to be very careful about this kind of study, though, so that the study isn't biased. In other words, we want to make sure that the patients who choose to be in the BMP arm aren't different from the patients who don't choose. One of my concerns is that the patients who choose to be in the arm may have more severe involvement than the patients that don't, and that could definitely affect our results, and we need to control for all of that when we look at our statistics. Some other potential CER trials that we can think about in the future is when we compare two different surgical techniques, both of which are claimed to be highly effective. Right now, the group that I work with mostly uses this intramedullary rod technique for pseudoarthrosis treatment and followed by casting. There are other groups that use this external fixation procedure, and you can see this device that's placed on the leg and stays on there for quite some time. It's called an Alizarov frame, and their groups also claim very high success. But there's no way that we can really reliably compare those two results at this time. Everybody uses different measures for how they determine success. So I think we could certainly think about designing a CER trial where we have a standard outcome measure for different types of treatments like this. So just some future opportunities that I think will be out there for comparative effectiveness research, and that will include looking at different MEK inhibitors for NF1 tumors, which one works best, comparison of the best drugs for ADHD, and using standard outcome measures like the RAINS committee has worked on can help us in better comparison of these drugs. So that is all I have to say about that, and we're going to have Dr. Welling speak next, and then hopefully we'll have a few minutes at the end to bring all the speakers up and have more questions. Thank you.